This conference will now be recorded.
Hi, John. How you doing
Hey,
tonight?
John.
Yeah, doing great, thanks.
Good. And
Good,
one other
good.
person on the telephone?
Hey, Carl
Jake
Foreman
Curran.
here.
Say again?
Carl Foreman here.
Ah,
On the telephone?
yes.
Okay.
Yeah, we met Carl in Los Angeles last week at the PCRI conference.
Right.
Yes. Good to see you both.
Good to see you. And
Yeah,
you're pulling what we call a Dennis Correa, where you show up on the phone and on the web. But that's okay.
Right now, I'm having trouble getting on the website.
Oh, okay. All right. Well, Dennis always comes on the phone and the web. So now we've got two of you that are doing that. So that it's all right. It just confuses Jake a little bit. There's nothing wrong with confusing Jake, right?
No, and it's pretty easy to do, so I don't feel bad.
It's only because I have neither a computer or a phone that works reliably.
I see. Okay. All right. So, and Peter's on. I see Peter's name. Peter's joined us.
Hey, Peter.
Hey, Peter.
One more phone, Jay Curran, San Francisco.
Oh, yes. And Jay Khan.
Wait a minute. All right, I am confused now. Speak up again, Jay.
Jay Curran, San Francisco, California.
Oh,
I
it
thought
was
he
Jay.
was.
Yeah, it wasn't Carl. It wasn't Carl joining us in two places. It was Jay.
I'm going to stop listening to you, Rick.
Yeah, you do that. That's the smartest thing you've said all day.
I'm staying out of it.
Yeah, no, we thought Carl spoke up at the same time we asked who was on the phone, and we thought Carl was on the phone and on the web.
Oh, okay. That my confusion, my first time here. So yes, it's computer only.
Yes, don't worry.
No problem.
We're getting there. And Ken Anderson. Oh, and Les. All right, we've got a good group tonight. Oh, you're in business, Carl. You'll get a lot of opinions, I suspect.
So you have won me.
All right. So
We have Rich Jackson in Spokane, Gary.
Yes, I got one. Yeah.
Okay.
So let me just do a quick roll call of who I see on here, and then we're going to start off today with Carl, because he's never been on the call before, notwithstanding that Len and I know a little bit about Carl's situation. So I see Jake, Rich Jackson, Carl Foreman, Gary Gunville, Dennis Correa, Jay Kruckman, Paul Frieda, Len Sierra, John Appler, Peter Kafka, Ken Anderson, and Les Shelderup. Did I miss anybody? Okay. So.
I didn't hear you call Jay Curran.
Oh, and Jay Curran. Sorry.
Did you get Jake Buckman?
Yes.
Okay.
So Len and I, as you know, were at PCRI last weekend, a week ago, this past weekend. And we spoke to a number of people and encouraged them to sign up and come on the call. And one of the people that we spoke to was Carl, who has a difficult decision to make. His situation, he'll tell us about, is a little bit similar, but not exactly the same as Len's. He has signed up for a trial, and we asked Carl to give that careful consideration before he plunged into the trial. And I know he's calling from New Jersey.
Yes.
And Carl, what we would ask you to do is to spend the first 20 to 30 minutes just explaining your situation, and then the guys will respond, and we'll go from there. Are you comfortable telling us your situation?
Oh, yes, I've talked about it many times to many people, including you two gentlemen.
That's right.
So my story is as follows. So it might take the full amount of time here. I was recently diagnosed with metastatic prostate cancer. That was in June of this year. I had been having a steadily rising PSA over the past, I guess, 2 to 3 years. My urologist was watching it, and it was reaching a point where it was accelerating. The urologist expressed some concern. He said that I should have a biopsy. He could do it in his office. And I did some research. I found out about the MRI fusion guided biopsy, which I had, which I've been told is a lot more accurate than having it done in the urologist office. So I had the biopsy on or about June 8th of this year. And I got some feedback. But prior to that, I had been going to a oncologist, which I guess a few weeks prior to that, when my urologist suggested I need to see an oncologist. I said, an oncologist? Why would I need to see an oncologist? Do I have cancer? No clue, because it wasn't known at the time. I didn't have a biopsy yet. And the oncologist that I was using was really saying, oh, everything's fine. You have plenty of time. It's slow growing. There's no rush to do anything. And at my, I think it was my second or third and last appointment with this oncologist, the day before my biopsy. And I had spoken to him. I said, I want to remind you, I'm having my biopsy tomorrow. He looked at me and said, why are you having the biopsy? And it was like I was frozen. I didn't know how to respond. To the extent that we had talked about it previously, my PSA was rising. Prior to my meeting, that third meeting with him, my PSA was 5.7. It was 4.4 about 6 to 9 months earlier. So accelerating. And I also had some blood work a few days before this meeting with this oncologist. And towards the end of the meeting, other than me being in shock and frozen about his comment, as we were leaving, I said, oh, by the way, I had my PSA. What number was it? And he said, as a matter of factly, it was 20. So 5.7 to 20 in the matter of 6 weeks. And his comment was, well, I've got patients who have PSAs in the thousands. I wouldn't be concerned about it. So you're going to have your biopsy. It's going to be, well, more information is better than less. And okay, great. So the biopsy was done in a hospital in central New Jersey. They took 16 core samples, which I understand, I think 12 is a standard when you have it done in the urologist office. And that was around June 8th. Or June 13th, my urologist had called me on the phone. He said, well, I'm sorry to tell you that the news is not good. Out of the 16 core samples, 11 are positive for cancer. And the pathology report is just showing a Gleason score of 7-8. And he recommended that I have a second opinion for the pathology report, and he sent it on to Johns Hopkins. Johns Hopkins came back about a week or so later with their report, and I was told this is like the top pathologist in the country, and they came up with an even higher score that we're talking about now, 9, 10, 2 samples at 10, 2 at 9, some at 7, all various sizes. So even more serious. So I found another oncologist. It was really at the suggestion of the oncologist that I basically fired, who was a top person at Robert Wood Johnson in New Jersey. And he had talked to me about this clinical trial that had just started a few months earlier at the Cancer Institute of New Jersey in New Brunswick, and that I might be a good candidate for it. Although he said that if you wanted to do surgery, I would not find any surgeon in the country who would be willing to perform surgery on me being diagnosed with metastatic prostate cancer, metastatic in the pelvic bone. And there are a few small lesions that are in the pelvis. This was as a result of several diagnostic tests I had for the preparation for the biopsy. I had the 3T MRI. The 3T MRI, after that came back, a couple of people asked me, a couple of doctors said, it looks like you had some traumatic event in the pelvic area. Were you kicked in the joint, groin, or anything else? And I just could not think about what this could have been. About 3 years earlier, I was in a car accident. I had a fractured sternum, but they said, no, it's something more recent. So the insurance company would not pay for the MRI. I had to do the self-pay option, as I know it very well right now. The self-pay option, I ended up paying about $650 out of pocket for the MRI, but well worth it to have the fusion-guided biopsy done that way. I also had, I figured, well, it's probably a good idea for me to have a PET scan. Yeah, they agreed, but went back to the insurance company again. They said, oh, no, we won't pay for the PET scan. That got me a little bit nervous because I know that PET scans can cost thousands of dollars, $10,000, $7,000, whatever the range. I found a local radiologist who started his own diagnostic center and by the Jersey Shore in Manasquan. Dr. Kranicki is the radiologist. He's a assistant professor at Mount Sinai for their medical school. And what got me very impressed about him and his diagnostic center is that he had claimed that his machine, the PET scanner, is one of only 4 in the country that is the latest and greatest GE digital PET scan. I think it's an M1, whatever that means. And it's the latest and greatest. So, wow, okay, if I were going to have a PET scan, I would have to have it with him. Called up his office, said, hey, I need a self-pay option. They said, well, the self-pay option is about $2,000, but we will talk to Dr. Kranicki. This is the staff. So the staff said, we're going to talk to him while you're on the phone and see if he can do better for you. And they came back on the phone and they said he's willing to do it for $1,100. So I really thought, wow, I was willing to pay the money even more, but this is a bargain. So I went to him. I had a whole body PET scan. Then after the whole body PET scan, he said to me, we really need to do a bone PET scan. And it's a different type of an injection than the whole body bone scan. But since there are these lesions in the pelvis, we need to do more studies. And he says, you're a real puzzle to me. I don't know why I'm showing symmetrical lesions in your pelvis. I've never seen this before. Can you shed some light? And I couldn't figure it out. But then 2 weeks later, I remembered back in March, and so this was May. Back in March, I was on vacation on a cruise in the Caribbean. And while on that cruise on the land in St. Kitts, I fell. And I fell on my butt very hard. So he said, now that makes sense why it's symmetrical. And it's not necessarily a cancerous lesion, but, there's a couple of other lesions. But my conclusion is that, yeah, you have metastatic prostate cancer. And so that was in May. June 8th or thereabouts was the biopsy. Biopsy confirmed it. And so the PSA, I think I may have mentioned, the PSA jumped to 20 from 5.7. About a week or two later, I had decided in conjunction with my wife that the standard of care, as it's called, is that for a metastatic situation, I need to be on hormone therapy. The urologist had recommended that to me, and he said, well, I can give you a shot, and we'll start with Firmagon. It was a 30-day shot, and that was June 22nd. I got my 30-day Firmagon shot. He said, I prefer that to Lupron because with the Lupron shot, there could be a spike in your PSA. We want to get it under control because it's accelerating so quickly. So I recommend the Firmagon. Okay, did that for 30 days. The PSA went down from 20 to 13.3. Okay, nice drop, but still concerning. And he recommended, in conjunction with my now fired oncologist, that we should go with Eligard, which is a 3-month shot, and start with a daily dose of Zytiga with prednisone. The Zytiga, as we all know, is quite an expensive drug. Thank God for me, Optum RX is the prescription drug company that is used through my wife's insurance plan, and there's no copay, no out-of-pocket. I started that. I've been on it about 2 months now, and the last PSA as of a week and a half ago, is now 0.32. And the alkaline phosphatase, which I quickly learned that's an indicator of bone disease, and let alone the metastasis. The alkaline phosphatase, which was a high of 248, and the upper level of normal was 117. So that's now down to the normal range of 90 from 117. Okay. So at this point, I also been doing my own research, and it's just incredible to me. If I wasn't doing all of this research, I wouldn't have known to ask these questions, and nobody is coming forward to say to me, yes, you should have considered the MRI fusion-guided biopsy, or yes, you should have started on this type of hormone therapy, and on and on. So I know I have to be proactive. That's why I saw you gentlemen out there. I thought it was well worth it, and it actually was well worth going to that conference. And so the clinical trial now, my medical oncologist is affiliated with the clinical trial at the Cancer Institute, Dr. Soraya, and Dr. Isaac Kim is the, I forget the term, but whoever heads the clinical trial, he's the head of the clinical trial. They are, as I said, it started back in March. They are looking to go global. They're looking Australia, South America, a couple of other countries to get them all in on this trial. Although the total number of participants, they're only expecting 190 total participants. And it has to be for individuals who have been newly diagnosed with metastatic prostate cancer. And there were two, it's a randomized trial. So there's Group A and Group B. So Group A is those individuals who are having standard of care and nothing else, which is what I'm having with the hormone therapy. The Group B would have standard of care plus a robotic radical prostatectomy. So I am in the Group B. I am scheduled for the surgery by Dr. Kim on November 14th. Dr. Kim has done approximately 1,700 of these procedures. I had a routine scheduled visit with my cardiologist, who I see every 6 months. Not that I have any heart issues, but I had a very high-stress job over the past couple of years, which I had been laid off, and thank goodness for that. A lot less stress. I even think that's less stress than what I'm dealing with now, because I've become knowledgeable about what questions to ask and everything. And I think I'm on the right path. Although the cardiologist said, he said, you know, if you're not 100% certain that this is the right thing to do, to have the surgery and to have the hormone therapy, you need to see this doctor. And I actually have an appointment with that doctor. His name is Dr. Mark Stein. He's at Presbyterian in Manhattan. And he's got I'm impressed by people that have Harvard, or he's from Yale and some other high-level degrees. And he said, this is a guy who's really going to help you either tell you, yeah, you're on the right path or not. And so I'm looking forward to meeting with him at that point. Also with my latest meeting with Dr. Soraya at the Cancer Institute, I expressed to him my concern, and this was right after talking to you two gentlemen and the conference. And he said, you know, a month ago, you were 100% certain that this was the right thing. You were looking forward to have the surgery. Now you're not there. And I said, well, I'm not. Questions that are being asked have been being posed to me. And so I can leave the trial at any time prior to November 14th. So Dr. Isaac Kim, I would guess he had a conversation with Dr. Soraya, the oncologist. And Dr. Isaac Kim called me, left me a message. The bottom line is that I'm meeting with him, the head of the trial, on October 9th at around 9 a.m., talk about it in greater detail. I guess my greatest concern, well, take a step back. The clinical trial, the purpose of the trial is to determine how the survival, extending survival by having surgery with an individual like myself with a metastatic disease. And so, you know, there's no guarantees. And Dr. Kim, the surgeon, had told me early on, he says it's upwards of 30% incontinence. And then I was drilling down a little more into that. And Dr. Soraya went on his computer at our meeting this past Wednesday. And he says, yeah, here are the statistics with Dr. Kim and the 1,700 plus operations he performed, but there's no differentiation between whether it's encapsulated or if it's somebody who has metastasized cancer. So, but at the end of 1 year, there was 98% no longer any incontinence for any of the 1,700 patients. So that made me feel quite comfortable because I believe that is something that's probably the largest side effects, less aside from the fact that they can cut the nerves for erectile dysfunction. I said, well, I guess I could live with that, and the incontinence over the first couple of months of surgery, which over time will virtually disappear theoretically. I know that's not necessarily 100% certain, but so. That's what they showed me. Both Len and Rick had sent to me an article about a study that was done comparing surgery with radiation, saying that the survival was better with radiation than surgery. And interesting enough, and I have so many files at home here, and I found a file from an article relating to the City of Hope from February 2015. Labeled Breakthroughs, Cancer Insights, the Benefits of Surgery for Aggressive Prostate Cancer by Bertram Yu, MD. So it was a positive article about the surgery option. And then there was an even older article that I found from 2010, Medical News Today, Surgery for Aggressive Prostate Cancer gives 92% 10-year survival rate. So these are some positive articles which I am going to bring to Dr. Stein, in addition to the one that you gentlemen had sent to me. That doctor also now has, I fax over him to 50 pages worth of documents, including blood tests, the 2 pathology reports, and the notes on the various scans that I have taken. And with all that information, we'll see what he has to say.
So let me interrupt you because I want to make sure there's time for discussion of this, Carl, and that's a pretty good summary. There's a couple of things that stand out to me. The first is I asked if you had run the nomogram for surgery. Have you done that? The Memorial Sloan Kettering, I think I sent you the link for that. Have you run that?
I'm not familiar with that to run something. I know the article read the article that you had sent me, but
yeah, I think I'm almost certain I sent you the nomogram, but I'll put the nomogram in the window here. So let me explain what a nomogram is if you're not familiar. It's It reviews results from a large database. In this case, the database is the experience of Memorial Sloan Kettering. And it tells you what the likely outcome is for you based on people who have very similar disease demographics. So if you were to go to, hold on a minute, and I'll put the nomogram. I know you'll find it in the email where the email where I sent you that reference, that link. It's in there, but let me put it here, right here in the chat window, and I'll send it out to everybody. There you go. So if you go to that site, you'll have to agree to a couple of things first, and then you'll put in your Gleason, you'll put in your PSA, you'll put in how many cores, how many were positive, et cetera, et cetera. And what it's going to tell you is how successful your surgery is likely to be.
Okay.
And I can tell you in my case, and I did not have anywhere near the numbers you have, there was a 30% chance of success from surgery alone. So the likelihood is that you're going to have to go through radiation, even if you have the surgery. So the question you have to ask yourself is, if I'm going to go through radiation, first of all, let me step back one. If you definitely have metastasized cancer, and it's a little unclear to me whether you do or you don't. You certainly have very aggressive cancer, and there certainly are some questionable marks in your pelvis. And what I would say is that a good medical oncologist, genitourinary medical oncologist, that is probably going to give you a more comfortable opinion as to whether you have metastasized cancer or not. But if you do have metastasized cancer, in up until 4 or 5 years ago, other than at Mayo, nobody did any what we call debulking. They didn't operate on the primary tumor, either with radiation or with surgery. Mayo always did that. And they've been doing it for years and years and years. They always thought that debulking was the right way to go. Now, they may be correct. Memorial Sloan Kettering did a study about 3 years ago. I'm trying to remember how many men were there. I think it was a pretty smallish study. I cannot remember. I have the study. I can find it. But what they found was that at the end of 20 months, there was no progression of the disease in men with metastasis, but it was too short a period. You can't really evaluate a study on 20 months, even though they got a lot of publicity with that study. Now, the question is, if you're going to debulk, why would you debulk with surgery if you're probably going to be faced with radiation anyway? Or, one could argue, well, you won't go through the radiation because you're already on hormone therapy. But then the other side will be, well, if you've gone through the debulking, you may as well be sure and get rid of everything that's in the pelvic area because it hasn't gone further out. So, why not just do the radiation if you're going to debulk, which is kind of what Len did. Forego the surgery, which we know has significant side effects. Two other issues. I got to question that 98% at the end of 12 months. It just seems too low. I mean, we've been in this game a long time, a couple of us, and it's probably more like 5%. I would say that was the global average from memory, but I'm not sure. Could even be higher. And there's a lot of statistics on that, and you need to verify that yourself. So, I'm always worried about surgeons who oversell themselves. The third thing is, we know Mark Stein pretty well. He was the doctor of a guy we love dearly who passed away earlier this year. And he was his doctor at Cancer Center in New Jersey and Rutgers. And then he flipped over to New York Presbyterian to work with Charles Drake. But for me personally, he would not be my choice of doctor for a second opinion as a GU med onc. I would, as I mentioned to you, I would go to Dana Radcliffe or one of the Memorial Sloan Kettering docs.
Well, interesting you say that, because you did mention her name to me, and we did try to contact her office. And what's kind of interesting, I guess if you want to call it politics or whatever, but I had a second opinion meeting with Dr. Zhao in Basking Ridge at Sloan Kettering, and so I'm in the system. So when I requested an appointment with her, they said, well, you have to get a sign off by the doctor that you had been with. And you know something, it's been over a week. I haven't heard back from them. It's like,
well, look, I can't help you with internal politics. I can only tell you who I think would help you the best there. I mean, here's my concern with Stein. Stein's a bit of a salesman when it comes to clinical trials. We know this because he was pushing the Listeria trial forever and a day. And he pushed Jim into it. And I personally think it was a mistake. We told Jim at the time, but he wanted to do it. And he's a good doc, but he just wouldn't be my choice based on how he treated Jim Harrington. But that's only one person. I think we've had one other guy that went to him. I'd have to look in my database. But we do know him. We know who he is. I mean, he's not a bad doctor. But for me, I would be wanting to use one of the GU med oncs on 2nd Avenue, not at Baskin Ridge. But having said that, I'm going to just throw it open to some of the other guys. I've given you a few things to think about, and please run that nomogram. Len, do you want to kick off?
Well, I was trying to find statistics on incontinence following prostatectomy, and it seems like nobody really knows. There was an article from the journal Reviews in Urology, a highly respected journal from 2014, entitled Post-Radical Prostatectomy Incontinence, Etiology and Prevention. And they have a chart of studies of post-prostatectomy incontinence and the causes, and they're all over the place. The rates, they're all quite high, actually. And that section starts off with this sentence: incontinence rates after prostatectomy vary in the current literature and can be as high as 80%. Now, of course, there's stress incontinence, which is kind of a minor nuisance. And then there's sphincter incompetence, sphincter incompetence, and that's a much bigger problem, which would require men to wear a pad all the time. So, Carl, as I think we may have told you at the conference, the one thing you learn, and the more research you do, the more this lesson is driven home, that in treating prostate cancer, there's very little agreement on anything. So all you can do is, as you've been doing, do your due diligence, do your research, make a decision in coordination with your doctor, and never look back. Whatever you do, don't try and second guess yourself after you've had whatever procedure you choose.
Right, and you sound like my daughter, which I may have mentioned to you guys. My daughter is a nurse, and not currently an oncology nurse, but she was an oncology nurse, and she had even said to me, she said, "Look, you've done a lot of research. You were comfortable with this decision of having the surgery, and she's a proponent of moving forward in that direction.
Mhm.
But
Well, our interest is only to see you travel the path of least harm.
right,
And if we're, I can only speak for myself. If I'm opposed to surgery in your case, and we don't give medical decisions, but I can tell you I did not do surgery for the very reason I explained. And we just don't want you just to see you go through additional side effects. I mean, for me, I think there's a bunch of things you've got to establish. You've got to be very sure that you have METs, because clearly the abiraterone and prednisone is working, but that's a tough treatment. And if you do not have METs, then it may be early to have done that treatment. So you really want to establish you don't have METs. You've got to make this decision on debulking. And I personally am in favor of debulking. I know Len is in favor of debulking because he did it. And we'll ask the other guys. So, those are a couple of things. I posted a couple of links for you on incontinence, which are a little more, I think, a little more realistic than what you're seeing. But let me open it up. Who would like to talk to Carl? Or who would like to discuss this issue with Carl?
I'd like to clarify a few things.
Go ahead, Larry.
So I missed I got on the call a little late. Maybe I missed this, but did you have a bone scan
yes,
and that lit up? Basically, you mentioned 2 places in the pelvis.
yeah, multiple. Actually, the doctor from Sloan Kettering said that there's significant areas that have lit up, and including those 2 asymmetrical lesions, which after analysis with several other doctors, they said, yeah, that's not relating to the cancer, that's relating to your fall, but there are still other lesions in the pelvis which were confirmed that I do have the metastasis.
Oh, and they did a biopsy of that?
No, they did not do a bone biopsy, and the medical oncologist who I originally used, the way he described a bone biopsy, he says it's extremely painful, and because of the scans that you've done, the MRI, the PET scans, and he basically says if it looks like a duck, it quacks like a duck, it's a duck. That's what he said. So I don't want to put you through the bone biopsy.
That's kind of interesting, because that's the first thing I thought about was that, I mean, some bone biopsies, the spine or something, it really, if it's a small spot, but one of the first things that I went through kind of a similar thing. I was jogging and I thought I hurt my hip, and then the doctor said he found a hernia, and then they did a PSA and it was extremely high, and then they said, well, let's clarify this with a hip biopsy, and I had that biopsy for the hip. It was really minor. The prostate biopsy was worse because I had the old style to go through the tushy. I don't know. If you want to think about if it's really metastatic, if they can find an actual lesion, at a distant point, I just thought that might be affecting the decision you'd make. And I don't think if it's a pelvic biopsy and it's in a big enough spot for them to feel like they could really get decent samples, it wasn't any big deal at all. I was sore for a couple of days, hardly at all. So just a thought I had about, clarifying what the lesions, what the bone scan was indicating might be metastasis before coming to a firm decision. Maybe that wouldn't make any difference in your decision, but I'd want to know that. That's my thought.
I guess so, and you mentioned that you came in a little bit late, but the PET scan the bone PET scan that I had it was done from a machine that there's only one of 4 in the country. It's the most detailed digital PET scan that is available today. Well, one of those 4 machines is at actually Harvard University, and one is at this imaging center that I went to in New Jersey.
Yeah, but what's more important than the machine is the agent. Is the what do they call it, Len? The dye, not the agent. What do they call it? The contrast.
Yes.
It's the contrast. What contrast did they use?
The sodium fluoride.
Sodium fluoride. That's F18, isn't it, Len? Is that F18?
Yeah, radio tracer is what they call it.
Yeah, the radio tracer. So, the F18, you're probably better off with C11. You're even better off doing an Axumin scan. I mean, what you might want to do now is get yourself an Axumin scan, because that would confirm. Or better still, a gallium-68 PSMA scan, which is really going to light up anything that is prostate related. So, it's not, don't be wowed by the machine. Yeah, I mean, the MRI, was it a 1.5 Tesla, a 2 Tesla, a 3 Tesla?
The MRI was a 3 Tesla. Yeah, 3T.
It was a 3 Tesla. So, it's important. The machine's obviously important, but I think the agent is equally as important. And probably if you're trying to establish that this is definitely prostate cancer related, then you really want to see if you can find yourself a PSMA scan, because the PSMA agent essentially only sticks to prostate cells, with the exception that there are some cells that express PSMA in the esophagus that are unrelated. But ideally, for what you're thinking about and what Larry Fish is saying, to ascertain whether in fact these are prostate cancer metastases, a PSMA scan or an Axumin scan might be worthwhile. Who else would like to chip in here and talk to Carl?
Yeah, this is Dennis, and I started out like you, very similar. PSA climbing pretty rapidly. I didn't have the advantage of the MRI fusion, so I just had the old style biopsy done. But mine came back with a 5+4 9 Gleason, and then I went in and I got the scans done, and mine was clearly metastatic. I had at least 5 bone mets in my lumbar area. And at that time, and this was just a couple of years ago, and the explanation I got was that, kind of like the horse is already out of the barn here. And the studies that was showing were that chemo with docetaxel, with starting at the same time you start ADT, which in case I started with Firmagon to not get the flare, and then switched over to Lupron on a 3-month Lupron. But that took me down very significantly for a little over a year before I started to have another progression. And then I was added the abiraterone and the prednisone. And now I'm below less than 0.1. But I still have the metastases, but I don't have a lot of the side effects that many of the other gentlemen on the call have due to the radical prostatectomy, radiation, and so forth. Yeah, I have lasting side effects from the chemo, but nothing that's really keeping me down. And I have to agree so much with Rick about the scan, and to me that would be all important in making your decision. You've done a lot of research, but gather as much data as you possibly can, so you can apply that to the research to make your decision.
Anyone else? Peter, you're very quiet.
This is Jay Kern in San Francisco.
Go ahead, Jay.
How old are you, Carl?
63.
Okay. I don't know if this is relevant, but at the conference, Dr. Scholes, I think he had one time written a book called The Prostate Snatchers. Maybe out of date by now.
Yeah, I did buy his most recent book that was available at the conference. I haven't read it yet.
Okay.
Well, The Prostate Snatchers is a good read, but it's probably worth getting it from the library only because the chapters that relate to your situation where there's metastasis, I think there's only 1 or 2 chapters on that from memory. But it is a good read. I wouldn't disagree. Peter or Rich, you just showed up on screen. I mean, you were diagnosed metastatic, correct? And what was the discussion there about debulking?
No, I'm not metastatic. I've got 9s. I got 5 9s on the Gleason. The urologist that did my biopsy, the first thing he looked at me and said is surgery is not anything he would recommend with 9s. What I chose to do was started hormone with Casodex and then Lupron, followed by high dose brachytherapy, followed by 25 doses of external radiation. The basic premise that I kept bumping into with all the doctors was that the odds are with a 9, it's coming back. Their thought was, and my thought as well, was why go through all of the side effects of surgery and then go through all of the side effects of radiation again to go with it. There are a couple of studies that with combination therapy with brachytherapy, with external radiation, and with hormone treatment, the 8s and 9s and 10s are responding rather well. If you've got metastatic, again, the surgery is not going to remove the problem. As they said, the horse is out of the barn. So you're still looking at radiation. For me, the side effects were just entirely too much for surgery, and then I'm still staring at radiation. That's my 2 cents worth.
Thank you. Thanks. Peter, do you have anything you'd like to say to Carl?
Can you hear me?
We can.
Okay. Carl, how's your blood pressure?
Blood pressure is well in the normal range. I think my last was 117 over 68.
Okay, keep an eye on it while you're on Zytiga, because it can affect it somewhat. So just keep an eye on it.
Okay.
Yeah, I heard when you were speaking earlier, I heard you say that. Correct me if I'm wrong. The study you were looking at said that the incidence of incontinence after surgery was 98% after 1 year. Which
No. Well, the other way around. The of no incontinence at 98%.
Right.
It was no.
Right, but it was after 1 year. It was not right after surgery.
Right after surgery, it's 30 to 40% over the first month or two, and then it kept declining after that up until the year mark.
That makes a lot of sense. So I just wanted to reemphasize, guys, that it was 98% after a year that that most symptoms would go away. That makes a lot of sense. There aren't that many guys that have incontinence a year after surgery, but it does happen. Okay.
Right, and of course, at the LA conference, when I was listening to the sling and the sphincter and all these additional necessary procedures for people to repair their incontinence, that got me concerned.
Yeah. I had surgery. I had sling surgery at the same time as my robotic surgery. And I came out of surgery totally continent. But I had other issues going in. But anyway, so I'm not going to comment too much. I mean, you've got a lot of big decisions to make. The other question is, does it show any kind of spread beyond the prostate? You know, is it escaped from the prostate? Is it in the seminal vesicles? Is there any indication of anything like that, or the lymph nodes?
No.
But there is indication in the pelvis.
Yes, in the bone, right. There were a couple of lesions.
Right. So you see, there's a couple of things here that just are inconsistent. The alkaline phosphatase going from 248 to 90 is a very, very good sign, and probably would suggest that you could have metastatic cancer, or whatever type of lesions you had were no longer either destroying bone or creating bone, even if they were not related to cancer. Yeah.
Right, and also just to add to my therapy, and I don't think I had mentioned it, or if I did, I forgot. I have had the Caregivers shot as of last week to add to control the bone.
Okay. But the other point, as Peter correctly says, is the cancer has to get to the bone. So in order to get to the bone, it's got to go, it goes through the lymphatic system. So it would be strange to see no lymphatic metastasis, but only metastasis in the bone. You'd expect that there would be something, especially before treatment. You'd see something in the lymph system, and then you'd see something in the bone, because it goes to the lymph system before the bone, and you don't see that. This is why I'd encourage you to do an Axumin or a scan, or better still, a gallium-68 scan, PSMA scan. Because there's just, it's a strange situation, Carl.
Yes.
Anyway, you know, we've given you a heck of a lot. Is there anyone else that would like to say anything before we move on and I go see who would like to talk today? I mean, we've spent about 50 minutes or so, we've given Carl a lot to think about, and
yes,
we're here for you to discuss these issues at any time.
Great, thank you.
Okay. All right. So let me run down here and see who would like to take some time today. Jake, you're not getting off the hook today, mate. We're going to start with you. Even though you switched your camera off, are you still with us? Well, I think he stepped away. He knew what was coming and he stepped away. All right, we'll come back to Jake when oh, here he is. Are you there, Jake?
I was in the bathroom. Sorry.
You were hiding in the bathroom, is that right?
Oh yeah, right.
Okay. All right. So we know you've got something to talk to us about this time. Yep. Rich, do you have anything you'd like to talk to us about? Yep.
I bumped into a study about Erlita as a monotherapy.
Yeah, we can talk about that. We'll give you a tick for that one. We'll come back to you.
Okay.
Gary Gumville, anything for you today?
I'm good tonight, Rick. Thank you.
Okay. Dennis, anything for you tonight?
Nothing. Thanks, Rick.
Okay, Jay Krutman, would you like to raise anything?
No, I had blood drawn today. I'll have results tomorrow and a meeting with my doctor Wednesday, so next week.
Okay, keep us posted. Don't hesitate to be in touch if you need to run anything past us.
Thank you.
Paul Frieda, anything for you today?
Nothing for me tonight, thanks.
Okay, Len, anything for you, sir?
Nothing for me, Rick.
Is John Appler, I think, left? Yes.
Yeah, I
okay.
think
Peter, anything you'd like to raise today?
Yeah, I can update you on my last results and my.
Super.
And it's-
Okay. Mr. Anderson in Phoenix, anything for you today?
No thanks, Rick. Just hanging out.
Okay. Les, anything you'd like to discuss today?
No, I do have a quick question just about this system, but it'll only take a few seconds.
Yeah, we'll come back to you. We saw your man. We saw your man, Mr. Kwan, Dr. Kwan, at the conference. He was as popular as ever. Jay Curran, anything for you?
Yeah, I got a couple of questions about a couple of the speakers at the conference.
Okay. Larry Fish, anything for you?
No, Rick, thanks. I'm okay this week.
Okay. Did I miss anybody? Okay. All right. So, Mr. Hannum, we let you off the hook last week, but I think you should share what you're seeing and just listen to, you don't have to act on anything, but listen to what some of the guys might want to comment on. So why don't you give them an update?
Okay. I did try to see the end there, but you were last week. I don't have time.
Yeah, because we have 1 minute left. That's why.
All right. Well, anyway, I had a blood test on the 31st of August, and my PSA. I'm on enzalutamide and Lupron, and also bisphosphonate. My PSA had been holding steady at about 0.7 for 4 or 5 months. Before that, it was 0.5, then it was 0.6, and 0.7, and it held steady for, like I said, 6 months. But then this last time, I went up to 1.1. So I don't know why. I just, you and I talked offline, Rick, and I talked to Len. I am going to have another PSA test at the end of the month. I'm not going to wait 2 months.
Good.
Yeah. So
you mean Len is more persuasive than I am? Is that it?
no, not necessarily.
Okay.
He's more easily persuadable.
Okay.
No.
Well. So, I mean, I think the question here for the guys to consider is, and some of them have experience with this, but at what point do you start to get concerned that the therapy that you're on, especially if it's a second-line anti-androgen like abiraterone or enzalutamide, is not working?
Right.
Who would like to comment on that?
And that's what Len and I talked about primarily. I told him I don't want to panic. I'm trying very hard not to panic and just it's a slight rise, 1.5, 1.5 month doubling time approximately, but I still don't want to panic. It might very well stay steady at 1.1 for months at a time. I don't know.
Right. And that's a very smart thing to do because, panicking is the worst and it stresses you out. And so I think everybody would agree with that. But who else has had a rising PSA? Has anybody on the call had a rising PSA while on abiraterone or enzalutamide?
Yeah, Jay Curran in San Francisco.
Go ahead, Jay.
Yeah, I was down to 4.9 on Zytiga, and now I'm up to 32, and I guess that's over a period of about 3-4 months.
How many months, Jay?
3 or 4.
Okay.
And my doctor doesn't seem to be too concerned about it. I'll see him tomorrow. But I've always heard something about 3 consecutive rises. Is that useful?
Well, it's useful to be considered castrate resistant.
Oh, okay.
Not sure it's useful for anything else.
Okay.
Yeah, I'm already castrate resistant. I had been for probably a couple of years. Once the Lupron stopped working as efficaciously as I would have hoped. So I think I can safely say I'm castrate resistant, right, Rick?
Yeah.
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 And Jay, what are you on right now?
What I'm on is Firmagon and abiraterone and prednisone and Flomax.
Right. So you know you're already castrate resistant.
Yeah.
And who else would like to, anyone else like to chip in? Anyone else had a rising PSA on second line anti-androgens, or have any thoughts on what happens when your PSA starts to rise when you're on second line anti-androgens? Okay.
Well, Rick, I'd like to ask, what did your oncologist say would be a trigger point for your PSA before he decides he wants to do something else or something additional?
Is that for me or for Jay?
For Jay Curran.
This is Dr. Agarwal in UCSF, San Francisco, and what he said was he takes 3 things into consideration: symptoms, PSA, and scans. And so I got the scans done, and he'll look at them tomorrow.
Okay.
Okay.
Did somebody else want to say something right before Len, or right at the same time as Len?
I think that might have been me.
Okay.
One of the things that I wanted to ask about was, does anybody? Okay, we know that bicalutamide has the when your PSA starts going up, and then you stop it. Sometimes some people have an anti-androgen withdrawal effect, and since bicalutamide and enzalutamide are similar, I was wondering, has anybody ever tested that theory? You know, I was wondering if going off of it for 3 or 4 months might be a benefit.
I have not heard that stopping enzalutamide can cause a reduction in PSA. Has anybody else? I've never seen that reported, Jake.
Yeah.
I mean, it's a good question. It's a very valid question, but I've never seen it reported. Look, I think that if nothing else, the fact that you're willing to do a PSA test again at the end of the month is important.
Yeah, I agree with that.
I also want to harken back to what Agarwal says, which is he looks at symptoms, PSA, and scans. And I don't think you've been scanned for quite some time. Is that right?
Not since June of 2016.
So
That
sorry?
That was a CT.
Right. So, it probably makes a good deal of sense to scan, if nothing else. You know, you need a more recent baseline to see how you're responding to treatments.
Well, I have. Sorry, I hear a lot of people here. Is that me or is that somebody else? I have some mixed feelings about scans. You know, I don't like them. They scare me. I'm claustrophobic. And I also wonder about the value of them because I know it's already in my bones. I know it's never going to go away. So I question the validity and value of scans in the first place. You know, they're good for identifying new Mets or Mets that when you never had them. But I don't see the value of them when you already know you have Mets. That's something else Len and I talked about. And you and I talked about it, Rick.
Would anybody like to address that?
Well, in your case, Jake, let's not forget that you still have a prostate.
Yes.
So a small rise in your PSA from 0.7 to 1 or 1.1, for all we know, could be normal prostate cells.
True. That's very true. Another reason for me not panicking.
Right. But also a good reason to get another scan. Like Quan said at the PCRI conference, scanning is not just everything, it's the only thing. So without a scan, we don't know if the lesions are progressing or not. We don't know if it's in soft tissue, lymph nodes, or advancing in bone, or not advancing at all, which would be the ideal case.
Right.
So I don't know. I wish somehow you could figure out a way to get scanned, something that doesn't involve a claustrophobic reaction.
Well, MRI is definitely out for me. I can do a CT scan if I have to, and I did a PET scan once before, and I made it for about 45 minutes before I freaked out.
That's a long time, 45 minutes.
Well, yeah, they wanted to keep me in there for like an hour. But yeah, the PET scan was what told me I had Mets in the first place. But you know, when we talked the other day, Len, you made an extremely valid point, which I cannot argue with, is that you know the Mets. I know I have Mets in my bones. Whether they've increased or not, they probably have a little bit. But you know, you made a good point that they might very well have spread to soft tissue. You know, lung, liver. I cannot argue with that. So I'll ask her when I see her on the 20, I think the 28th of February of October. I mean of September. Don't get nervous, Rick. I'm going this month. I'll ask her if there's any scans that would be appropriate this time. And you know, to answer your question, Len, about you know, what's her threshold? You know, Agarwal, you know, told Jay, you know, he's went from 5.9 to 33. He's not concerned. My oncologist always says, you know, unless I have you know, new pain, that her threshold is 10. You know, my threshold is more like 5 before I panic. But you know, but that's what.
And what did she say she would do if your PSA went to 10?
Well, that was when I was on Lupron, and then when I was on bicalutamide, and we haven't talked about it since then. But, you know, when I started going up after bicalutamide, then she put me on the enzalutamide. We really haven't talked about it. I was thinking I could try Zytiga, but then you came back with that horrible news that only 10% of people, you know, from switching from one to the other, only about 10% of the people actually benefit. So I'm guessing probably docetaxel will be the next in line. Her being an oncologist, especially, that's probably what she'll want to do.
Yeah, there's no harm in trying Zytiga, though. I mean, you'll know pretty quickly whether you respond or not. And if you're in the 10%, 10, 15%, you might get something out of it.
Yeah, that's true. I am a gambler, so I think I told Lynn I've been known to draw to an inside straight.
So, anyone else want to say anything about to Jake? Have anything else they want to add to this conversation?
Yeah, this is Jake Kern in San Francisco. Does any of those anti-anxiety things help you, or will they let you take that going into a scan, like Effexor or something like that?
Yeah, no, I've taken them and they help a little bit, but like I said, they
Okay.
start wearing off after about 45 minutes.
Okay.
At 45, I mean, that's for a PET scan, which is a much bigger tube. MRI is definitely out, and my oncologist keeps saying, you need an MRI, and I keep saying, I'm not going to get an MRI. So, but again, it's because I don't believe that scans are that valuable anyway.
Okay.
I
Well,
wonder if they could give you something like propofol, where you're basically unconscious. Yeah, I would ask your doctor or radiologist, Jake. Surely they have patients in your circumstance who get claustrophobic, and ask them what are the strategies for helping the patient cope with that. What kind of meds can they give them? Wouldn't it be nice if you could sleep right through it?
Yeah, I would.
If they could first give you the propofol, then quickly kind of strap you in so you don't move. And
isn't that what they give? Isn't that what killed Michael Jackson? And isn't that what they give patients before they execute them? Thanks a lot, Len. I thought we were friends.
Michael Jackson was getting it every night just to sleep, and he'd be out for 8 hours. He had a constant IV drip going all night. That's not what we're suggesting for you.
I know. I don't know. That's further down the line. I don't really want to think about that.
all right. Well, look, we beat up on Jake enough. We've got two concessions. One is he's going to get a PSA, and two, he's at least going to discuss scans. And that is real progress from a week and a half ago or so when so Jake,
I do listen to you, Rick. I do listen.
Well, I have to give more credit to Len than to me, I think.
I do listen to Len too.
There you go.
I depend on your advice, so I appreciate it.
So, because we care, that's why. And so, just keep us posted and come back and talk to us. But we just want you to try and figure out where your disease is at so you can get the best possible treatment, Jake. Right. That's it. Okay. Rich Jackson, you and several other people saw a post by Al Fat on Inspire regarding Alida or apalutamide, that's the generic name, monotherapy. We know Al Fat. We've had dinner with him. He's been on this call. And so this concept of a monotherapy, whether it be with Alida or Xtandi or abiraterone, is getting kicked around now. Rich, would you like to maybe summarize what Al posted, and maybe we can talk about this a little bit, because I'm sure that there are guys on this call that are interested in Al's situation.
The basic summary is that gentleman had Gleason 9. He'd had surgery, had salvage radiation administered with curative intent, had Firmagon for 7 months, and for the last 4 of them, his PSA had plateaued at about 5. Testosterone level was 2 to 3, well below castrate. And what he decided was that rather than becoming officially castrate resistant, he talked his oncologist into a clinical trial to study Erlita as a monotherapy, and he got approved. The results of the first month were surprising. His PSA dropped from 4.85 to 0.37, and his testosterone went up to his normal, which was 191. Nobody expected that, and right now they're just kind of watching to see, how long he can maintain it. The second month's results, his PSA dropped from 0.37 to 0.17, and his testosterone level continued up. So they're not sure exactly what the combination is. It's an unexpected result, but he now has testosterone, which there have been other tests that they talked about doing bipolar testosterone, doing ADT and then testosterone injections. So perhaps he's, working something there, but it looked like I'm not at the point where it is going to directly affect me, but I can see something like this in a couple of years down the road. And it looked like a break from, ADT forever and then just continue piling drugs on top of it.
I have a couple of questions, if you don't mind. I saw that article also, thanks to Len. Does anybody know if, first of all, has anybody sent for the email or for the article summary that he's writing, and did they receive it?
I didn't receive it, no, but I did ask.
So did I, but I didn't get it. Second of all, was Al, is he metastatic or not?
Yeah. According to my notes, in 2017, which must have been the last time he was on the call, February 17, he said that a bone mets were now being seen.
Okay.
Were now observed.
So that makes it even more interesting to me, anyway.
So one thing I'm not clear on, Rich, you say his PSA went from 4.85 to 0.7. Had his PSA got as high as 4.85 whilst he was still on the Firmagon? Did he tell us that?
The way that the article is worded, let's see. He was on Firmagon for 7 months. Okay. And for the last 4 of them, his PSA plateaued at about 5. In spite of the fact that his testosterone levels were well below castrate. The last 2 tests for testosterone were 3 and 6.
What was his highest? Does he indicate how high his PSA got?
The only thing I'm seeing here is a 5 on
okay, well, I know that his PSA increased to 62 with a doubling time of 3 months. That was back in late 2016, early 2017. He was always reluctant to go on ATT. But, maybe one of the things we can do, rather than speculating, is I can send him an email and ask him if he'll come on the call and talk about this. That would, I think, interest a lot of guys. And if he agrees, then I'll try and let you know ahead of time when that's going to be. But the bigger issue, I think, is the validity of these monotherapy trials. Len, would you like to give us your thoughts on that?
Well, as Alex commented in his posting on Inspire, he said this was a clinical trial of N equal 1, basically, a one-person clinical trial.
Yeah.
So, how can you comment on that? It's basically, we're talking about a case study. And they're going to follow him, and we'll see what happens. In an email to Rick and Jake, and I can't, maybe Peter was on the distribution list too. I was thinking, okay, so apalutamide is a very similar structure to enzalutamide and even to bicalutamide, which is Casodex. So we already know that Casodex monotherapy, it's been studied for years, and there is a lower overall survival with Casodex monotherapy versus dual therapy with Lupron or some other similar agent. So there's that negative to it. And there's the issue that Jake alluded to earlier about the possibility that Casodex, we know if your PSA starts to rise, it could be due to the Casodex, and sometimes they'll withdraw the medication and your PSA will fall. I wonder if we might see something like that with monotherapy with either enzalutamide or apalutamide. But of course, we have no data, so we really don't know. This is all, it's very intriguing and kind of exciting. I mean, isn't that wonderful if you're going to have a high testosterone and meanwhile your PSA is plummeting? Who doesn't want that? But I guess we just have to either take a chance or take a chance on it, or just wait and see what happens with Al. And there was another guy who replied to Al's posting who said he was on enzalutamide monotherapy, and he had a similar experience, even more remarkable. His testosterone went to catastrophic levels, and his PSA went to undetectable. What bothers me about these guys is on Inspire, you can post your profile and you get a person's entire history, but neither one of those two guys posted anything. So I have no idea what their background medical story is. Like, I was surprised to hear from Rick just now that Al at one time had a PSA of 62. He didn't mention that at all. So I'm wondering, how did he get his PSA down to 5 when he decided to go on monotherapy? If it was 62 and he was on Firmagon and he says it's creeping up to 5, something happened in between. I don't know what it was. But I guess that's all the only comments I would make.
Just as a word of explanation, both these drugs, Standy and apalutamide and also bicalutamide, they act on the androgen receptors. So the concept of the drug is that it blocks the androgen receptors from attaching to testosterone. It fills up the little clamps they have to grab onto the testosterone. So if these androgen anti-androgens have totally occupied the androgen receptors, it makes sense that if you took the drug, it doesn't matter what your testosterone level was, the prostate cancer cells couldn't grab onto it because they're occupied with by these anti-androgen drugs. So, in theory, it makes some sense. It's the same idea as guys who are given high dose bicalutamide, 150 milligrams a day instead of 50 milligrams a day, and no Lupron, no LHRH drug, and their testosterone starts to rise. But, we've never seen great success. There are some people that had some success from bicalutamide monotherapy, high dose bicalutamide monotherapy. You don't hear about it so much anymore, but 5 years ago, there were a lot of people talking about high dose bicalutamide, high dose Casodex. I think the reason you don't hear about it so much anymore is there's people that were considering high dose Casodex and now probably looking at some of these newer drugs instead. But that's the explanation of how you could have testosterone in your body and your cancer wasn't growing. The drug that stops you producing testosterone is the LHRH drug, which can be one of several: Firmagon, Lupron,
Eligard.
Thank you, Eligard. I'm having a mental block, but there's about 4 or 5 of them, and or maybe more, and they all work slightly similarly, except for the Firmagon, and then there's one other LHRH drug which works like the Firmagon. It's an antagonist rather than an agonist. I forget the name of it. But that's the explanation. Would anybody like to give us some thoughts on this monotherapy, because it is intriguing? And there is a trial, by the way. It was mentioned that they're considering a monotherapy trial. I can, at the appropriate time, I can probably dig in and see if I can get more information, because it's a Janssen drug and we have a good relationship with Janssen, so I could find out. I will try to find out. I'm not going to say it's immediate because I have to pick my time, but I'll try and find out when that might be starting.
This is Recurrent in San Francisco.
Go ahead, Jay.
There's a fellow in the Mountain View support group in California, and he was carrying PSAs of about 70 for about 14 years, and then it went up to about 200 or something. And he works with this doctor, Dr. Dormady, and so this guy had been reading about studies in Sweden or Europe or somewhere where they went monotherapy on Xtandi, and that worked for him for a couple of months, but apparently it's not working now because I think he's gone on Taxotere.
And did he have to go to Sweden to do that, or was he able to get was he able to get the enzalutamide here and do the monotherapy here?
I think everything was done here.
Okay. The one thing that is interesting to me is how Al Fat's doctor, and I'm not sure who his doctor is now, but how he was able to convince Janssen to give them the supplies of apalutamide to try this, but I don't know.
Well, it wasn't apalutamide. It was straight Xtandi.
Yeah, no, I'm talking about Al Fat.
Oh, okay.
I think he said he got approval from his insurance company, if I'm not mistaken, based on that article that Len referred us to. Didn't he say he got it from the insurance company approval?
Yeah, I believe he did. Of course, maybe they didn't tell the insurance company that it was going to be Erlita monotherapy. Maybe they just naturally assumed he was going to continue Firmagon. So if you could get him to come and talk to us, Rick, on the next call, that'd be great.
Yeah, I can't guarantee the next call, but I will certainly write to him and see if he can be available in the next few weeks to speak with us. sooner rather than later. Yeah, I don't know how he did it. I mean, the thing is that Alita's been approved for non-metastatic castrate resistant, and this guy appears to be, I mean, at least when he last reported to us, he was metastatic castrate resistant. So again, I don't know, just don't know. But just keep this on your horizon, because as I think it was Len said earlier, or Jake, you know, there's a lot of people that would like to be taking a single drug and have high levels of testosterone and also have their cancer controlled. It would make a lot of very happy campers.
If I started chasing my wife around, I'd have a heart attack.
I didn't hear that.
I said if I started chasing my wife around a room, she'd have a heart attack.
That would just make her easier to catch.
Okay.
I wanted to add, Rick, is just I don't know how many guys are aware of this, but this is something that would definitely not work with Zytiga monotherapy, because Zytiga does not block the testosterone receptor. It stops testosterone production,
right,
or synthesis. So
right.
Don't think about Zytiga monotherapy. That's not an option.
Thank you. Thank you. Thank you. Okay, we're moving right along, and the wheel stops at Peter Kafka.
Can you hear me?
We can hear you.
Okay. Just as an aside, I was just thinking, has anybody heard recently from Eric? I don't remember seeing him for the last number of weeks.
We saw him, I think when you were not on the call about 2 weeks ago, I think he was on, or 3 weeks ago.
Yeah, one of them weren't on the call.
Okay.
Say again, Len?
Eric was on the call in one of the weeks that Rick was in England.
Right. There's been about 3 or 4 weeks.
Yeah.
Okay. Just wondering, as long as someone's in touch with. Okay, my situation is that I'm blood test back yesterday. I'm down to back. I went down further. I'm in the undetectable range, 0.06. So my agreement with Dr. Turner is if my blood test came back good in terms of PSA, I'll do a shot of Lupron in October, a month from now, when I go back through there. And then essentially wind down the Lupron and the Zytiga by mid-November, and it go off for a while. And that will be kind of in the midst of my proton radiation. Just let it go out, and after the proton radiation, just keep an eye on things and see how long I can last and how it goes. About that, I'm pretty positive. So that'll be about 7 months that I take and Lupron. I'm weathering it well, and I'm sensitive to it. Happy about trying to take another holiday and see how far it gets, and then I can always go back if things point in that direction a year or two down the road.
Mm-hmm.
So that's where I am. Heading back a month from now. I'm going down to San Diego to do a setup scan. Go home for a couple of weeks, and then back to San Diego for the month of November.
Mm-hmm.
And I guess one more thing I could mention is that I requested from Dr. Turner to get a Foundation 1 test to check for MSI reading for me, and they're going to do that. They're going to send away and get my prostate sample from UCSF, and test it all, whatever it is, 250 genes, as well as MSI. And, should know sometime in the next month or so what the result is. That's covered by Medicare now.
Right. And of course, that's to see whether, if you ever needed it, you would be a good candidate for Keytruda pembrolizumab, correct, Peter?
Correct.
Okay. Well, I mean, it's great news that your PSA is undetectable. We like that. Do we not?
Fantastic. Congratulations.
Yeah, that is good news.
So, yeah, I mean, what are your thoughts on all of this? You don't sound enthusiastic. I mean, is that because you're sharing a hotel room and you can't yell and scream right now, or is something on your mind?
No, I'm very enthusiastic. I'm a little bit subdued, I think, because I'm tired. That's all.
Okay.
Head down to the gym after this call. Maybe that'll perk me up.
Okay.
I haven't been feeling great the last couple of days, but I'm really happy about this. I have no concerns. I think I'm on the right track, and I'm pretty good. Yeah.
You know, there's a lot of lakes in Minneapolis. I'm sure that there are some outrigger clubs there. Whilst you're there, you can look around and see if you can go borrow an outrigger and paddle on one of the lakes up there.
Yeah, there's a lot of kayaks. I can rent a kayak anytime I want. There's plenty of kayaking around. Yeah, it's pretty good. It's a pretty cool place.
Yeah. Okay. Anyone else like to talk to Peter on his results and his strategy and embarking pretty soon on more intermittent ADT?
Yeah, Peter, you've had your scan, so you know where those abdominal lymph nodes are. But now that you're undetectable, when they go to proton therapy, I guess they'll just be targeting those same lymph nodes that were positive on your last scan. They're not going to be doing any additional scanning if you're undetectable. Would that be right?
Yeah, no additional scanning, but I believe they are going to target some additional lymph nodes. Yes. Well, actually, they are going to do a scan, CT scan, when they set me up. But they are going to be doing some prophylactic scans, because the likelihood of microscopic metastasis in some other lymph nodes is very plausible. So that's why I'm going with the proton beam rather than just the Wacom SBRT.
Right.
How is your blood pressure doing? You mentioned it before, and I know it was high from the Zytiga. Has it come back down into normal range, Peter?
Yeah, but I'm taking meds for that. I'm taking to keep it in check.
Okay. All right. Anybody else want to say anything to Peter before we move on?
Good news, Peter. Good luck.
Sure, I'll keep you.
Okay. Okay. Jay Curran, you're up. And then lastly, we'll go to Les.
Okay, this is Jay, and about 5 days ago, I had the pleasure of seeing a poster of you rowing a boat at the Prostate Cancer Summit in Oakland, Alta Bates Hospital. I don't know. This picture was of a younger Rick, I would think, but anyway, it was interesting.
Yeah, it was about 6 years ago, as it so happens, and I think I gotta find it. I think I have a picture. They gave me a picture, but I can't remember what I did with it. Oh, wait a minute, here it is. I'll show you guys. This is, they did a photo shoot. This was in So wait a minute here. Can you see that? This was from that same photo shoot. It was done by a doctor who was involved in the hospital, and I met him at Marine Rowing, and he took a lot of pictures. So, well, that must have been the ultimate thrill for you. What can I
Well,
say?
anyway, at the conference, I didn't get a chance to hear Dr. Kwan, but I kind of got the feeling that you had some reservations about him. I don't know if you want to talk about that or not. If not, I got another question.
Well, I have to be very careful before I say anything, because I got to first of all check and see. Well, Les is a Dr. Kwan patient, so I really, and I've been through this before. I mean, my greatest concern with Dr. Kwan is whether he's qualified to treat advanced cancer patients as a surgeon. But he's not alone. I mean, there's the Canadian crew that do that. You know, a couple of clots, and there's another guy up there. There are surgeons treating advanced cancer patients. I did discuss some treatments he was recommending with one of the other highly reputable doctors who was at PCRI, who was presented for many years there, and he actually agreed with me. But if he treats with success, as he does with Brian Heisey and other people, then he's going to continue to attract new patients. I don't know, Len, would you like to say anything about Dr. Kwan?
What I noticed in Dr. Kwan's lectures at PCRI is, number one, he's highly opinionated, and he doesn't always necessarily back up his opinions with data. Unlike Rick's radiologist, who said, you know, everything he does is based on data. The other thing is, Dr. Kwan talks a lot about his successes, but very little about his failures. So you get the impression that he's a miracle worker and that hopeless cases arrive at his door and they're cured. And no doubt there are such cases, and those are the ones we hear about, but we never hear how many failures he's had with these same approaches. I would limit my comments to that.
Okay, this is Jay again. The reason I ask is that hopefully I'll be able to move back to Illinois, and so that would be closer to go up to Males. But anyway, my second question is, I did hear Dr. Yu.
Hold on a second. Can we let's just comment on that. Where, if you move back to Illinois, where in Illinois would you be?
I would be about 70 miles west of Chicago and 30 miles east of Davenport, Iowa.
Okay. So if you were 70 miles west of Chicago, there's no question in my mind as to who I would want to see, and that would be Alicia Morgans. Because I just think she's phenomenal. I don't know how many of you, I actually tweeted this out today, but I don't know how many of you saw her piece, A Million Faces, which is a piece she wrote on prostate cancer awareness. I can probably link it if I get a little space and time before we finish, but I did tweet it out today. and it was just a wonderful piece. And I think one of the things that stimulated that piece is that she lost her grandfather to prostate cancer, albeit age 91, earlier this year, or the end of last year, I forget. I just think she's an outstanding doc. She's a great GU med onc. She's tied into all the best people around the country. And I don't know why I would ever want to let from 70 miles west of Chicago to Rochester, Minnesota, when I could head 70 miles east and go to Northwestern and see a terrific doc. So that's me personally, but that's what I can say. And I will also say that, and it's to some extent true. I mean, we've had good and bad, and I'm going to ask Les. We're going to go to Les next, so he'll have plenty of time to rebut me. But I will say that with Alicia Morgan's, everybody that we've sent to her loved her, and we're so grateful. Jay Krutman, who's on this call, Rob, God rest his soul, and a couple of other people that we've sent over there, and they all love her. So if that's where you plan to be, for me, I don't think I could do much better than getting her to run my treatment.
Okay. I heard Dr. Yu speak, and then I talked to him, in question and action period. And I have this gene that might be helpful called CDK12.
Mm-hmm.
And I'm thinking, is that something that would be just something that would help me with Keytruda or with other immune type things?
So I think there was a recent paper, Dr. Yu probably knows a heck of a lot more than this than I do, but there was a recent paper that suggested that CDK12 could be actionable, and it's a very common gene in prostate cancer. But as I recall, and this is just my memory, they're not quite sure yet how it can be actionable, but they're looking in to try and figure out where they go next. But it's a gene that is under scrutiny because they think that it might do something. Len, do you know anything about CDK12?
Yeah, I believe it's a DNA repair defect, and that they would use the PARP inhibitors against CK12.
Okay.
I'm not sure about Keytruda.
Okay.
I'm just looking to see.
I think he said that there was an article about 2 or 3 weeks ago in Cell magazine.
Yeah.
I haven't had a chance to look at it yet.
Here it is. I got it. CDK precision therapy, immunotherapy. I got it. Are you on the phone? Oh, you're on the phone. That doesn't help.
Yeah.
All right. Let me just pull it up. Just bear with me a second and I'll tell you where it is. Because I definitely remember reading something recently about CDK12. So it's good that I found it, because then that assures me that I'm not going around the bend, because sometimes I think I am. Okay. Immunotherapy and precision medicine. Okay, CDK12. Okay, so I read about it on the Prostate Cancer Foundation site. I'm going to put the link in for those of you who are on the web. Okay. And the headline says, PCF-funded study identifies a unique subset of advanced prostate cancers with mutations in the CDK12 gene, which may be sensitive to treatment with immunotherapy. So, what I suggest you do, and the date is June the 14th, 2018. So, if you can, when you get onto your computer or go down the library, however you do it, and it was published on that same date, June the 14th, in the scientific journal Cell, as Dr. Yu said.
Okay.
So I did read this. I suspect that the article is pretty technical, Jay, so you might just do better reading the summary on the prostate cancer site, which is very readable, and the discovery was done at University of Michigan. So again, if you're going to schlep, you instead of going northwest, you can go east and get to Ann Arbor as well.
Okay, thank you, folks.
Okay, and let's finish up with Les, who had a quick question. But Les, I really feel like you're so good in not interrupting us, and I feel like you should have every opportunity to rebut whatever we have to say about your doctor.
Well, first for Jay, I'm also from Illinois and just across the river from Davenport. And I've been seeing Dr. Kwan now for 5+ years, something like that. I'm still alive. So much of what was said by Len about Dr. Kwan, I agree with, but I haven't seen any real need to get away from him anyway. So I'm so far hanging with him. I'm going up there tomorrow to start proton beam therapy to the abdomen, which leads me to the question. I'm going to be away from my computer for a matter of 5-6 weeks. If I can steal a computer up there, can I just use the website that you show from your email? Just keep using that same thing and get on from wherever I am?
Sure.
Okay.
I mean, in the email, there is the link is in the email, so you can use that link. And the other thing is you can always phone in, Les.
Yeah.
There's a dial-in too.
Yeah. I don't like to use that because I did the first time I come in, but there was no way to mute. So if anybody in the house makes a noise, everybody can hear it, like we've noticed previously. So
yeah. Well, look.
Anyway,
I mean,
I also just had a blood test before I'd go up there, and PSA is less than 0.1 and testosterone is less than 7, which I wanted to get a baseline before we started the proton beam treatment.
Okay, and you're on ADT right now, correct?
Yes.
And what on Lupron, on enzalutamide, on
Lupron. On Lupron now, yes.
Okay. All right, I'm just making a quick note of that your PSA is.
No, we'll have that tomorrow.
Peter, could you mute for us, please? Thanks.
Update me.
All right. Yeah. So, Jake, could you mute Peter? Thanks. Well, we wish you every success. I'm sure Peter's going to be very interested to see how you do, since it's pretty much the same treatment that he's going to be following. I mean, it's kind of interesting that we have two guys here who are both choosing proton beam to abdominal lymph nodes. And so I think we'll have a study of n equals 2, Len.
Yeah. Pretty exciting. Let's hope it's equally successful.
We really hope so.
Yes, I was happy to communicate with him on email to find out what he's going to do too. It was kind of interesting, like you say, to find somebody else that's doing the same thing or similar anyway.
Jake, could you do me a favor and just post our URL into the chat window for Les for the room?
For what?
Well, isn't that the same thing as that you did from your email?
Yes. Yeah. I was just trying to make you like.
Yeah, I just copied that onto a thumb drive, so I'm going to take it with me.
Perfect.
Okay,
all right.
Thank you. I'm not very computer literate, so I just wanted to confirm if am I able to get on from up at Rochester. Thank you.
Okay. And Jake was just kind enough to post a link to a commentary and for where you can actually go to the actual article that Alicia just wrote. I actually sent her a little note of congratulations on that article. It's just a real heartfelt article. It's not particularly about advanced cancer. It's just it's a piece that she wrote because, as some of you know, September is Prostate Cancer Awareness Month, and that's what generated it. Okay, Les, was there anything else that you wanted to ask us before you embark on this journey?
Thank you very much.
It's a pleasure. It's a pleasure.
Rick, we have somebody else who just joined us a couple minutes ago on the telephone. I don't know if you want to.
Well, actually, a while back, and I blew it. I saw them and I forgot about it. Who came in on the phone late?
Dan.
No. Somebody came in on the phone about half an hour ago.
Yeah, this is Dan.
Hello, Dan.
Hi, Rick.
Sorry I didn't check in with you before.
No, that's okay.
My timing for the meeting was perfect. We finished right at 7 o'clock, but tell us would you like to talk to us about anything?
No, not much. I'm just doing okay. Went through my fourth chemo treatment 2 weeks ago. Got about 2 more planned, so I'm still hanging in there.
And how are you feeling? How are you doing? How are you managing the chemo?
Okay. After the second or third day, I feel miserable, but it takes a few days, and taking some pain pills along with omeprazole and then the anti-nausea pills. But I'm doing okay otherwise.
Well, I'm glad to hear that. I mean, I think we've got enough guys that have done chemo on this call, like Ken and Dennis and others. And I think that's sort of par for the course. You sort of have a couple of days of a high from all the steroids, and then you have a real low for about 3 or 4 days, and then you sort of have several days where you're kind of just in between until you get to the next cycle.
Yes, exactly.
And that sounds like where you are.
That's correct.
Have you seen any results from any test results?
No, really, my PSA is still holding steady with the third treatment. It just hasn't jumped a lot, but the worry is that it's going to be doubling every 3 to 4 weeks. So, who knows with my next treatment in another week or so. We'll find out. Okay. But I'm scheduled for scans tomorrow and Wednesday.
Okay. Jay Curran, have you done chemo yet?
No, I have not.
Would you consider it?
Well, maybe if my support system gets better. I mean, I've been moving close to my niece and her husband. They're empty nesters.
Well,
by the way, Jay, Rick was right about the CDK12 being a good target for immunotherapy with the checkpoint inhibitors like Keytruda. I just quickly read through that article link that he posted, and that's what they said. So definitely talk to your doctor about Keytruda for your mutation.
and you know,
Thank you.
the other thing is maybe to talk to people like Dan, and we can put you in touch with Dan. Dan's in San Francisco, you're in San Francisco, because, you know, Dan was an ABC guy for many, many, many years. And he finally figured that, you know, this is maybe the best way to go. And now he's 4 into it. And how bad is it, Dan? I mean, you never wanted to go near this, and God bless you. You submitted to the chemo. How bad is it at the end of the day?
I think it hits me, but maybe on the second day that my bones ache. But I tolerate it. No fevers. Just take some steroids as scheduled. But tolerate it, and if need be, the ibuprofen or hydrocodone, or AKA Narco. So I'm tolerating it as much as I can.
One other thing that I wanted to mention for all of you that I picked up at PCRI was that, you know, that there is a thought now, contrary to what I was led to believe, and I take my hat off to Jay Curran because he's been pushing for this for a long time, that it is better to get the lutetium-177 earlier in the disease cycle. And, you know, even before chemo. I forget which of the docs either said that or said that to me. It might have been Dr. Almeida who said it to me in discussion with him. Or it might be something I heard from one of the docs. But, you know, the idea of doing lutetium earlier in the cycle is definitely on the table if you can get it approved, or you can find a way to get into a trial. All right.
Rick, has lutetium-177 been approved yet, or is it still only in trials?
It's in trials. But it's in trials, but it is accessible at no cost in a number of places. It's accessible at cost as well, but there are trials now starting up in various places, and trials that have already started where you can get the lutetium at little or no cost.
Okay, thank you.
Okay. Len, anything else you want to add?
No, nothing from me, Rick.
Okay. Well, that's about it. If there's anybody on this call who happens to be fasting tomorrow, I wish you an easy fast. And I will be back next Tuesday, which is the 25th. And we'll speak to you then. Good night, everyone.
Night, everybody.
Okay.
Good night.